thank you everybody for making time on your Thursday to be with us at the National Council of Substance Use Interest Group. My name's Alexandra Plante, and I'm a senior advisor of substance use disorder at the National Council for Mental Wellbeing. And I am super excited to be joined by Dr. Sandeep Nayak today. So we will introduce him a little bit more, but this is the introduction to psychedelics for the treatment of substance use disorder. So just a few housekeeping things before we get started. Everyone is joining on listen only mode. Feel free to introduce yourself in the chat and say hello and meet people and exchange information and ideas. Questions can be submitted via the Q&A function or the chat function, and answers to these questions will be on our member-only Engage platform post webinar, but we can send answers around via email. I will just put in a plug that there are other National Council interest groups on other topics like individuals with intellectual and developmental disabilities, rural health, older adult, crisis response, etc. So if you're interested, you can check those out, and a little bit later at the end, I will drop the direct link to these interest groups in the chat so that you will have them. Last two quick reminders. The PowerPoint, the presentation deck, and the video will be available after the webinar and sent around via email. That's the number one question we get on these things is, will the presentation be available? And the answer is yes. Yes, it will. There also will pop up a quick post-webinar survey. I would love it if you'd answer the 3 or 4 questions to, I don't know, let us know what you're liking, not liking, etc. So without further ado, we are so lucky today to have Dr. Sandeep Nayak. He's an assistant professor at Johns Hopkins, and he completed his medical degree at Brown University and a psychiatry residency at Johns Hopkins Hospital. He's focused on investigating psychedelics as treatments for substance use disorders and mood disorders. Dr. Nayak also works as a psychiatrist at the Addiction Treatment Services and the Center for Addiction and Pregnancy at Johns Hopkins Bayview Medical Center. So we are so excited to have him here today. All right, so I'm going to kick things off with a little bit of an introduction, but today when we talk about psychedelics, we're talking about relating to or denoting drugs that produce hallucinations and apparent expansion of consciousness. So that's the rough definition we're going to use. An interest in psychedelics in research has grown significantly in the past 20 years in the realm of research. As visualized in this graph, you can really see starting in about 2000, just there being a jump in publications as reported on by the Journal of Frontiers of Psychology, excuse me. So why is there potentially interest in psychedelic assisted therapy for addiction or substance use disorder? And I think a couple things come to mind. One is that there are challenges in current SUD treatment and SUD in general, fatal overdose, high reoccurrence rates, but not higher than other chronic conditions, but still high. Treatment retention rates being what they are. And then there being a higher need than those that actually receive treatment. So needing more access to treatment. And then, of course, high healthcare costs associated. Internet search data also suggests that interest in psilocybin and psychedelic therapy really increased during the pandemic, when we also saw an increase in depression, anxiety, and addiction. So there's some potentially, something correlated there. Additionally, there is reported kind of more favorable side effects to traditional medications like psychedelics. So for psilocybin, for example, there are transient headaches and maybe mild to moderate transient anxiety. But when you look at, some traditional SSRIs or, other psychotropic medications, those side effects can be much more severe and long-lasting. And lastly, I think that there are many positive initial findings coming out. An example is psilocybin was found to reduce depression and anxiety related to racial trauma, as well as a reduction in alcohol and drug use after psychedelic experience. This is just one example, but that study was published in 2023. So there's some promise there. Additionally, if we're looking just specifically at kind of the history of addiction and substance use disorder in America, we can't forget Bill Wilson, one of the co-founders of Alcoholics Anonymous. He was a proponent of LSD, and a quote from one of his letters is, "Some of my AA friends and I have taken the material, LSD, frequently and with much benefit, a great broadening and deepening and heightening of consciousness." So there's just some history there to kind of an interest at the intersection of SUD and psychedelics. Another kind of just foundational element that I want to cover is just around what substances are we actually talking about. So there's kind of a class of classic psychedelics, which have been around and known and used for many years, often with historical and cultural underpinnings. LSD, also known as acid. You have psilocybin, which is what we're going to talk about today, which is kind of slang magic mushrooms or shrooms. We have DMT, also known as ayahuasca, mescaline, which is peyote, and then ibogaine, which comes from the West African boga plant. Newer psychedelics are often synthetic offshoots of sort of classic psychedelic compounds, sometimes not. You have MDMA, known as ecstasy or Molly. The one on here I want to point out, though, is ketamine. So it's not technically a psychedelic, it's a dissociative anesthetic, but it has psychedelic properties, and it's very often talked about along with other psychedelics as a result, but it is a little bit different. So how do psychedelics work? I think this picture of sort of the representing the brain does a pretty good job. So on the left side, we see kind of the brain connections during a routine task, maybe like driving a car. There's a lot of filtering of stimuli and distractions, maybe selective listening going on, but there are just sort of a few highways in the brain being utilized. Then you look at kind of the hub connections on the right side, brain connections on psychedelics, breakdowns of connectivity within a node, and we're talking across brain centers. So on the right, on psychedelics, you really see this kind of whole brain communication going on. And a term we're hearing more and more interest in is just around neuroplasticity. And there being new connections between neurons being formed in psychedelics, which is, of course, neuroplasticity. A little quote here, but psychedelics induce the brain to change transiently in ways that appear to allow a reset to take place and permanent alterations in previously stuck ways of feeling and thinking about things. And that's from Mass General Brigham. But just kind of how they describe the kind of effects they have seen of psychedelics. And what is it like to be on psychedelics? There are kind of 8 sort of common things that happen. So visual and auditory hallucinations, which could be seeing vivid colors or patterns or shapes or hearing sounds that may not actually be there or be present. Alterations in time and space or perception. So time can seem to slow down or to speed up, and spaces can feel larger or smaller or distorted. Emotional intensification, so just really heightened emotions. You can feel like profound joy and profound sadness and euphoria, or just, very dark. Sensory intensification, so just increased awareness and sensitivity to sounds, textures, and visual details. Mystical or kind of spiritual experiences, so feelings of unity, interconnectedness, the universe, nature's kind of spiritual or religious insight. Ego dissolution, so just a sense of losing one's self-identity. and yeah, feeling merged with the environment, with the cosmos. And then the last two, so cognitive shifting, changes in thought patterns, which can be novel insights or creativity or altered states of consciousness. Basically, what results from this increased neuroplasticity and being in a transient-like state. And then the last one, which I'm particularly interested in right now because I have an 8-week-old baby boy, is synesthesia. So it's when one sense triggers another sense. So uh, you see colors when you're hearing music, or you're tasting something and hearing hearing a bell, or you are looking at blue but you're feeling something. It's a mixed match of the senses. And what's so interesting about that to me is in the very first few weeks of life, human infant has synesthesia. So my little boy Nash is, hearing a smell and whatnot. And one of the things that has been very intriguing to me around psychedelics is simply the ability for it to create kind of a infant-like brain, if that makes sense. So just to kind of bring us up to date, and Dr. Nayak actually will sort of debunk the myth that psilocybin research was kind of banned prior to 2008. But in 2007 and 2008, 2007, the FDA came with kind of a breakthrough therapy designation for MDMA to open up some research pathways for it. That happened then for psilocybin in 2018, just kind of opening up more kind of access to research around the substances. Just in the past few weeks, an FDA advisory committee rejected this 2017 study for treating PTSD after reviewing it. And that was done by a private company called Lykos Therapeutics. So yeah, psychedelics are mostly illegal. I will say as a state, Colorado appears to be kind of leading the pack as much like it did with cannabis in terms of some legalization or deregulation. Most of these have been through ballot measures, except for California, where the state legislature actually passed something, but then it was vetoed by the executive branch. So it is very much an emerging science. It's very much an emerging landscape politically, but nonetheless very interesting, and we're seeing it more and more across the news. So I am going to stop sharing and just get to my next slide. So welcome, Dr. Nayak. Thank you so much for being with us today.
Yeah, very happy to be here. Thanks for having me.
So we're going to break into a little bit of a Q&A, but I first wanted to just sort of ask about you. And I wanted, how did you get into psychedelic research? And I also was hoping that you could tell us a little bit more about the Johns Hopkins Center for Psychedelic Research and, well, consciousness and research.
Sure. So a bit about me. I mean, I'm a psychiatrist and my main interest is addiction. So if I wasn't in the psychedelic research field, I think I'd be treating a bunch of patients with substance use disorders. And that is my clinical work. And yeah, the theme, I think, of psychiatry, of substance use disorders is change, right? Helping people change. And as you know, we have treatments that are effective for a lot of people, but there's lots of people that are not well served by the treatments we have. And so really, I just come at this from a place of this may be a treatment that could help people. And it is, I think, I want to be clear when we talk about, psilocybin therapy, what's being studied is not just the drug, it's the drug and the psychological wrapper around it. So we do quite a lot of psychological support before, during, and then after the drug itself. So these findings that we're going to talk about don't necessarily extrapolate to to people taking it differently. Um, and so
Because
about
they're not delivered in isolation.
if they're not delivered in isolation, and the context, perhaps more than any other drug, the effects of psychedelics really seem to matter depending on the context. So we may not see the same types of effects or therapeutic benefits for people taking it in different ways. As
That
far
makes
as
sense.
the center itself, set and setting is kind of the famous word, as somebody said in the chat. But as far as like what Hopkins, right? So the leader who unfortunately passed away last year was a well-renowned drug researcher. He did a lot of work on caffeine. He's actually in large part responsible for why we all tend to think of caffeine as being like a drug. You get dependent on it. You can have withdrawal from it. But he got bored and he took up yoga and started having these really interesting spiritual experiences doing yoga and considered quitting science to sort of explore that more. And psilocybin was sort of raised to him, psychedelics were raised to him as a way of studying spiritual experiences in the laboratory. So he actually did not approach it as with a clinical interest at all. Um, and it's true. I mean, people do have like frank mystical experiences that seem to match the descriptions of religions around the world, and it happens with some regularity, not for everyone. So that was the initial reason for doing this at Hopkins. And sure enough, people had these profound, extremely meaningful experiences that they, among the most meaningful experiences of their life, that they continue to feel months, even years later, and also really enduring effects on their well-being. And so there is this, but it started from like studying non-patients, healthy people, spirituality, and then that moved into people with cancer who were struggling with, dealing with end of life. And again, you sort of see this is sort of an existential kind of therapy. So that was the first foray into the clinical work, but you can sort of see the thread. And it again, it like people had really tremendous improvements in their mood, in anxiety. And so this kind of led to, well, maybe we should start studying this, as a therapy for depression. And so right now, now we're talking like a decade later, psilocybin is mainly being studied for depression. And there are multiple phase 3 trials. So this is the final stage of development of drug development around the world studying psilocybin for depression. And so now our center does quite a lot of research on the psilocybin for various psychiatric and substance use disorders.
Wow. Yeah, it's very interesting. And I appreciate you sharing some of the history just because um, I didn't know it shows you kind of how we got from point A to point B today, where you, and we'll share a link in the chat, but are able to actually run clinical studies using psilocybin, buprenorphine, and um, yeah, for opioid use disorder. So it's very cool. I did sort of want to ask you, so specifically on the substance use disorder or substance front, what research has the center done into substance use disorder around and with psilocybin and psychedelics?
So in terms of trials that are fully done, there have been 2 trials of psilocybin for quitting tobacco. And in terms of trials that are ongoing, we have ongoing trials of psilocybin for alcohol use disorder. And I'm leading a trial of psilocybin for opioid use disorder. Just to give you I mean, the first tobacco trial was pretty small, handful of people, but 80% of them quit smoking. So whatever,
Wow.
small study, no control group. You can, don't pay too much attention to that. But then there was a bigger trial that basically half the people got single dose of psilocybin, half the people got nicotine patch, and they were all given CBT for smoking cessation. So lots of therapist contact. And this is not published yet, but the data is all collected, and it's roughly about a year later. It's something like 30% of people who received nicotine patch had quit. 30% had quit. And that's kind of actually around what you see in general. And 60% of people who received psilocybin, and again, this is a single dose. There's not ongoing after a couple of weeks. It's done, right? So quite a huge difference, and there's no real reason to think that this is a tobacco specific treatment. Um, so that's kind of
Yeah.
in the
Can
study.
you talk a little bit more too about sort of outside of the Johns Hopkins Center specifically, what research exists out there about psychedelics for the treatment of substance use and maybe across some different substances, like I don't know if they're for heroin or cocaine or that kind of thing?
Sure. So there's a bunch now. And I guess I should mention that there was research back in the day, like in the 60s and 70s on this topic. A lot of LSD for alcohol, LSD for heroin. Um, and there was some signal that it worked. It's kind of hard to compare. Many of those studies were frankly just kind of bad. Um,
Yeah.
and so there were some good ones though. The one for heroin was actually quite good and seemed to work. But yeah, there's studies of psilocybin for alcohol use disorder, including quite a large one that seemed to show it worked. There's a number of small studies for methamphetamine. There's one in Alabama for cocaine addiction. Um, yeah, there's not many people doing opioids actually. But yeah,
Yeah.
Bogan shoots
And
NYU.
I know one of the things when you and I were talking that you had pointed out is that I think there's a little bit of a misnomer or a myth that research into psilocybin or other psychedelics has been banned in the US during the last 2 or 3 decades. But that's not really the case. It's a little more nuanced than that. Are you able to just sort of explain for us how that works, that Johns Hopkins has sort of been able to legally continue to study psychedelics even when they're, the FDA wasn't kind of, yeah, on board necessarily?
Yeah, so psychedelic research, there's a lot of psychedelic research, and then it suddenly stopped. And it did stop because of, in large part, changes in government regulations, but also the public was like freaked out about it. And so the drug company that was supplying LSD also just didn't want to be involved anymore. But it wasn't banned in the sense that no laws had to change before the research could start again. It did require getting independent funding, which is not easy to do. And it did require gumption to navigate, frankly, years of bureaucracy to figure out how can we actually study this. And it also required an institution that, even though people in leadership at Hopkins kind of didn't necessarily want this research to start, they felt that they should support independent, like scientists who are pursuing projects for rigorous scientific purposes. But there was actually a lot of like kind of fear about restarting this research here. And so we just had the right person in the right place at the right time. Um, and Roland was like a very well seasoned drug researcher, impeccable reputation, not a hippie, like not, and frankly, that goes a long way for, and yeah, so there is a process. You get approval from the FDA, the DEA, from your local ethics board, yeah, your institute. I mean, it takes a long, long time, but it can be done.
Yeah. Well, it's just interesting because, the study that you all have put out on tobacco, just with that context, you realize how kind of hard won they were in a way, because they weren't easy to do. I was kind of hoping, so kind of with these studies, if you could sort of walk us through what a typical psychedelic assisted therapy session or practice might look like for both the patient, provider. So, like, how long is it? Kind of what's the setting? How many sessions do you think? Or dosing or format or cost, or if there are insurance reimbursements, anything like that that you can tell us to give us a sense of kind of what a session might look like.
Sure. So in some ways, they're a lot more similar than you might think, even though we're studying it for like opioid use disorder, depression, OCD, chronic Lyme, all kinds of stuff. There is real similarities. So there's three phases. So there's preparatory, dosing, integration. And the preparatory is meetings with the patient and two therapists, and that can take place over the course of weeks, but really spend anywhere from cumulatively like 4 to 8 hours of really getting to know them, building a sense of rapport, understanding their story, understanding their condition, but also kind of coaching them on here's the kinds of things that might happen under the effects of psilocybin, and here's how to deal with them.
Mm.
So people, when they actually get their dose, they've actually already been through kind of a lot of meetings, and the dose itself, it's a very internal experience. So it's not like talk therapy. People, and usually there's one dose or two doses. That's about it. Sometimes three, but it's really a one or two shot thing. And people are they spend the day, kind of the default posture is they're on a couch, they are wearing eye shades. So they're not actually engaging with the environment all that much. They're listening to music through headphones and they're lying down. And we encourage them to go internal, to go in, and to have an attitude of curiosity and acceptance and openness to whatever might happen. People sometimes laugh, and sometimes they sob for hours, sometimes um they just experience all kinds of things, and they don't even they sometimes they're experiencing contradictory things that they can't fully make sense of in the moment. And so sometimes we have a very clear understanding of what's going on in the moment, and sometimes we don't. But the important thing is just in that setting is us making sure that the person is safe. And so there's some somatic physical stuff that we have to make sure of, but that's pretty easy to manage, but also more psychological, making sure that the person feels safe and comfortable. And even if something difficult is happening, they are able to sort of engage with it. And there are
Can I
times
ask a question here?
where,
So when are the clinicians kind of inserting themselves or not inserting themselves? Like if somebody is crying, are they jumping in with questions, or are they waiting for the individual to speak to them? Or how does that sort of psychological safety work?
yeah, so there is a real sense for this kind of work where you have to let people kind of do it. You have to let people kind of go in, and you're there to support them. You can take that too far of letting somebody suffer needlessly. And so by this point, you've actually really gotten to know these people fairly well. And we kind of shouldn't be dosing people if we don't feel that way. Like this is a person that like we actually have a good sense of who they are. And if we're not, if somebody's crying, we may just ask them, how are things going? And usually they make it kind of clear if this is something that's, it's difficult, but they're doing okay and they want to keep engaging with it, or if they're finding like they're getting overwhelmed, or they don't know, what's going on or what to do. And so then you might sit them up, you might talk to them, but you talk to the patient basically.
Very interesting. And then I guess there's a last stage. So there's sort of the pre-dosing, the dosing, and then kind of what happens kind of once they have come down in the moments, days, weeks, months after.
So in some ways it's the more interesting part, the integration sessions or the follow-up. And so some people finish their session and usually there's a lot of meaningful content there. Not always, but almost always. There's like a lot of stuff that happened that informs their life in some way. And so there's a real now what? And people don't have to do anything with that, right? They could continue living their life the same way. They could forget about it, and people do. But I think that's a really important element of this modality is helping people uh, make sense of the content of their experience in a way that can actually be useful. And so some people, for example, let's take the example of a guy. This is a real case, but I'll change some details. But somebody who was struggling with alcohol, who had a lot of anxiety and lots of legitimate things to worry about, family, uh, parents' illness worked, and just led a very, very strained, kind of anxious life, and alcohol was sort of the way to relax and a way to avoid. And during the session, felt this kind of like extremely uncomfortable black blob, sort of building, 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 and he tried to turn away, but then realized like, oh yeah, yeah, I was sort of encouraged to try to go in, turn towards. And as he turned, and this is a very visual experience, as he turned towards this black blob, he began to hyperventilate, right? Like we could see this man sort of breathing very heavily. And then all these things started flitting by him, all his worries, one by one, by one by one, and it was overwhelming. But he went through all of them, every single thing that he's been avoiding. And it was devastating, it was difficult, but at the end of it, he realized that I actually can tolerate looking at the difficult things in my life. And that was his main this particular person also went on to have a mystical experience during that dosing session, but that was actually the lesson that ended up being most useful. I can look at the things that I avoid. I can deal with them. I'm strong enough.
That's very interesting. Yeah, especially when you break it down, kind of and go into the individuals and the things that folks are getting to. It's very interesting. And I'm also just in this individual story, this individual example, interested at how there was kind of a break between the biggest takeaway and the potentially like mystical spiritual experience as well. Um, you had sort of kicked us off with kind of your belief that uh, psychedelic assisted therapy is not just administering a psychedelic. It's not a kind of standalone thing or tool, but maybe getting at that, it's part of a larger array of services. Do you personally see psilocybin or psychedelics more broadly as compatible with 12-step programs, peer support programs, medication assisted treatments, traditional inpatient, outpatient therapy for substance use?
I sure hope so. I mean, this particular trial that I'm doing with opioid use disorder, I wanted actually to do it in a treatment setting where, I mean, it just makes a lot more sense, I think. But we actually couldn't find anyone that wanted to work with us. That and so this, in order to be really a practical treatment, well, one, we have to show that it actually does something, that it actually works, right? So I get that. But if it does, then we really do need to start figuring out how to implement this in the context of regular care. And so, yeah, I work in addiction settings and where, no psychedelics involved. And my sense is the places that I work would be pretty opposed to involving this kind of treatment at this juncture. But it's really early days, and we do need to like do the research and show that like, look, this actually seems to be effective, right? I think one of the places that I worked until 2 years ago was like very anti any psychiatric meds. Sorry, no, not 2 years ago, more than that, but like 5 years ago, anti-buprenorphine, and so there's like an education process that unfolds over time.
In your opioid study, which is happening in Baltimore, and so if folks know any like patients in and around the Baltimore area that might benefit, I dropped a link to a study, but that incorporates buprenorphine. No, yeah.
It does.
So that will, yeah. I'm very excited to see the results of that study. I know you're sort of bringing up that, I mean, culturally, the integration of sort of traditional substance use disorder treatment, it's evolving, but it's not there yet where it feels sort of comfortable kind of merging, you know, what's sort of a unknown area at this point into psychedelics. Um, with that, kind of what cautions or drawbacks or known harms or downsides, I mean, really known or unknown, that substance use providers sort of need to be thinking about with psychedelics?
Yeah, I mean, the fact that you can read news articles about psychedelics, this psychedelics that seem to be helpful for, right? That doesn't mean that people should just start using psychedelics to treat themselves. Um, I mean, again, these are not approved treatments. What we're doing is still experimental. And you hear about lots of people who do this, and then many of them may have good outcomes. But that is a caution I would, say is that this research is research. It's not ready for prime time by the usual standards of research. And there are people who should not take psychedelics. There are many people, most people, the majority of people who call or email who are interested in the trial are not eligible. And some of that is just because, maybe they were studying this condition, not that condition, but people who have certain cardiovascular conditions maybe are not safe to take psychedelics. People who have certain, bipolar disorder or psychosis, there are risks there. And then there's certain drug interactions, though actually not that many.
Yeah, and how often in the research has just sort of this classic idea of like a psychotic break or something through the use of psychedelics, what is known about that?
So people do get psychotic after using psychedelics. Um, this I've seen this, not in the research setting, but in the real world, right? In the emergency room. And so this is why if somebody has experienced psychosis before, we do not dose them. If somebody's mother has experienced psychosis or their brother has like so even we actually take family history into account, and would not and we've dosed, I don't know how many, we've done more than 1,000 sessions and we've never seen it happen. And yet this definitely does happen. And so that tells me that the precautions we're taking are working. But it's actually kind of hard to quantify, well, what is the risk for somebody who actually has these risk factors? We can sort of show that if we select people appropriately, this doesn't seem to happen, but it's actually, I don't actually know people who do have those risks, how likely is it? Not
Yeah,
100%, not zero.
very interesting. So we have two more questions, or I have two more questions for you that I want to go into that kind of look into the future a little bit and transition us there. But kind of how far in the future they, do you think it's a reality where psilocybin or other psychedelics might be kind of mainstream medicine for the treatment of substance use disorder?
I mean, so if psilocybin for depression, which is currently in phase 3 trials, if that gets approved, which, I don't know if it will or won't, then off-label prescriptions, I mean, doctors can prescribe a medication for essentially whatever they want. This is why you see ketamine for, like intravenous ketamine for depression. Once it's approved, you can do whatever you want with it,
Or
basically.
all these GLP-1s like
Yeah.
Wegovy and Ozempic for weight loss, and it's a diabetes type 2 medication. So yeah, that
So
opens the
so you might see it
case.
then and there. Um, but but well, yeah, I don't know. I don't know.
Yeah. And just because we're on the line with a lot of clinicians and behavioral health providers, what kind of training or extra training do you think would be necessary for clinicians to sort of properly educate themselves and their staff and their clinics to be able to use psychedelics as a tool in their programs?
So there are many trainings out there already. This is, take our $3,000 class and learn how to be a psychedelic therapist. And I'm a little frightened by a lot of these, to be honest. I mean, the heart of it, I would say, is that like all of the normal rules apply, right? So because this is like a really unusual treatment, but all of the basic clinical ethics of maintaining boundaries, don't have sex with your patients. My God, like the regular normal stuff. People are at risk of sort of losing track of that because this is like a fantastical treatment. So I think being a good quality clinician in general gets you 80% of the way there. The rest of it is learning more specifically about how the drugs work and how to help people navigate the experience and knowing what's normal, what's not normal. And that requires some all of this stuff is not built out yet, right? I mean, there would need to be, I think, in order for psilocybin to get approved, a process by which like standards that are set. And again, this is not an approved treatment. We're not there yet.
Yep, that makes sense. Well, this was so interesting to learn a little bit more about this. For folks that have kind of been to a substance use interest group webinar before, we are transitioning to a slightly shorter time frame, knowing that as behavioral health providers, we're strapped for time and resources and all that stuff. So we're going to wrap things up. I am going to just post in the chat again. Let's see if it pastes. Nope. Let me just grab that really quick just to post Dr. Nayak's email and again, a link to his study in case anyone is interested. But there we go. But thank you so much to everybody for tuning in on a Thursday. And thank you so much to Dr. Nayak for coming in. And we look forward to staying tuned about your opioid use disorder study and hopefully can have you back once that wraps up or when, I don't know, something big happens in this field to come give us an update. But thank you so much.
Thank you.
All right. Take care, everyone. Bye.